treatment, I put it from young in 2019. The strategy is excessive treatment. I think it is depend on every country resources. It is depend on limited resources, intermediate or high resources. If in still early stage, I think it is the definitive hepatectomy or ablation is resection for definite treatment. It is in high resources, it is maybe we can do that like ablation, resection, or liver transplantations. In intermediate stage, we can, in limited country resources, we can give a patient with sorafenib, and then in intermediate high resources, we can treatment with TICA or TIA or transartery radio treatment, TARI. When patient get advanced stage in limited resources, we can give the sorafenib or lenvatinib. Lenvatinib, we just know, it is established in 2017, and in country with resources in intermediate or high, sorafenib, if fail, can be changed to regorafenib or nivolumab, or maybe cabazitaxel or ramucirumab. It just depends on the resource we have. In terminal, maybe we only take the best supportive care. Yeah, it is the treatment algorithm from the BCLC. And we look back, if you look back from natural history, the survival of the patient, if there is definite like resection or transplantations, I think the survival is 5 years survival is maybe more than 70%. But if you have in like my country, the patient mostly enter the hospital with advanced state, frequently intermediate and advanced state, maybe we only choose that the patient with systemic therapy. Yeah, it is, I put from Lovett, natural, it is 2018 that we are looking that in lab, it is a strong positive recommendation, and the lab, it is a strong negative for recommendation. When it is with the level evidence that for the primary treatment, it is first line, it is sorafenib and lenvatinib, and the second line, it is regorafenib, cabazitaxel, or abiruzumab when alpha and more than 400 for the second line. And the other that it is ablations in patient with very early stage. It is quietly seem like resections. And transplantation, I think LT and LDLT and Milan, with Milan criteria. Yeah, it is treatment strategy for advanced state. We have told before that in advanced state, BCLC-C, portal invasion, or extrahepatic spreading, or intermediate state, BCLC-B, multinodular, progressing, or often local general therapy or failure from therapy, maybe the first line treatment, it is sorafenib with overall survival 0.99, 69 versus placebo, and lenvatinib, it is 0.92. The childhood plus ECOG below 2, greater benefit in patient with HCP infection alike for extra hepatic spread. And if there is sorafenib or lenvatinib failure to treat, so this is progression, It is the choice for second line. It is Rogarofenib, Agobajutimid, Raminavurumab, and Nivolumab. It is the standard therapy for the second line. It is the outcome, phase 3 clinical trial patient with advanced state. First line, it is alanpitinib. We know that many drugs have been done. You know that SEARS, SARAS trial, Birafenib, Linfanib, Erlotinib, it is failed to then Lenvatinib or Sorafenib. It is outcome of phase 3 clinical trial in patients with advanced state. For second line treatment, we know that the trial from Bayer, this, if there is failure for Sorafenib, it can be chosen to Rogarofenib. Cabozantinib and Rebrizumab for if alpha beta more than 400, it is eligible for second line treatment. We looked at Birafenib, Yepantimid, and everolimus. It is failed to treat establish treatment for second line. And now what we have after the first line and second line before? It is the phase 3 clinical trial in advance of XCC. Many a trial for first line with Sorafenib, Sunpitinib, Sorafenib, and what I told before, Sorafenib and doxorubicin, Sorafenib and Y90 series, and Sorafenib plus versus Nivolumab, Sorafenib Durvalumab, Sorafenib Zulumab, that they have two trials have positive for first line treatment. It is Alanpitinib is a reflect study. It's positive in 2017, and now it is in earlier or maybe the end of 2019 in BREP 150 is positive. It is Sorafenib versus Adalimumab and Bevacizumab can be for first line treatment for XCC. It's no strategic therapy for advanced XCC, and the others, it is Himalaya, Sorafenib versus Durvalumab, Sorafenib versus Tislelizumab, Rational 301, and Alanpitinib plus Alanpitinib, Pembrolizumab, Lab 002. Yeah, it is for phase 3 clinical trials in advanced treat. For second line, it is, we have data before that, it is Rogarofenib versus placebo in Rosa study it in 2016, and positive for the treatment, and Cabozantinib and Raburizumab, area 2, positive for treatment for second line for XCC. We have data from other like Bevacizumab is failed for the second line of treatment. Here it is a new treatment for advanced XCC. We have Adalimumab, Bevacizumab is significant and clinical meaningful improvement in both overall study of survival for unstable of XCC. It is Adalimumab and Bevacizumab, open label, plus versus Sorafenib in BREP 190 study designs. When we look in China study and global population that we have, Adalimumab and Bevacizumab well tolerated in Chinese population. So I think it is maybe for Asian people is maybe, I don't know, but in the next or later, maybe Adalimumab and Bevacizumab well tolerated too in population of Indonesia. And the other ongoing trial, it is Lab 002, Lenvatinib plus Bevacizumab. And it is Himalaya ongoing trial, Sorafenib and Durvalumab and Trivalumab plus Durvalumab. It is rationally 301, it's Reprimar plus Lumab. Yeah, I think it is the most new study and ongoing study. Maybe we have next data. I think it is my slides. My take-home piece is sorafenib standard of care for patients with FNXCC. Now we saw that lanfitinib non-inferiority efficacy compared with sorafenib and can be considered as first-line treatment in patients with advanced XCC without main portal pain invasion, clear bile duct invasion, and 50% of the tumor total liver volume occupancy. In phase 3 study for patients with advanced state XCC have been demonstrated regorafenib, cabozantinib, ramucirumab in the second-line setting, and now next picture that EM-BRAF 150 demonstrates statistically significant and clinically meaningful improvement in both OS and VFs for atezolizumab and bevacizumab plus sorafenib in patients with unresectable XCC who have not received prior systemic treatment. I think combination of atezolizumab plus bevacizumab is promising first-line treatment of unresectable hepatocellular carcinoma. Thank you for your attention.
Thank you, Dr. Lianda, for comprehensive talk. The next speaker is Dr. Rinaldi Lesmana. The title is Addressing the Unmet Medical Needs in Unresectable Hepatocellular Carcinoma, Lenvatinib Data Review. So, Dr. Rinaldi will discuss about clinical study of lenvatinib. And Dr. Rinaldi is staff in Hepatobiliary Division, Cipto Mangunkusumo Hospital, Medical Faculty, University of Indonesia. And Dr. Rinaldi Lesmana also the chairman of scientific session of this APASL 2020. Please, Dr. Rinaldi.
Thank you, Dr. Irsan, for your kind introduction. Good afternoon, dear colleagues, ladies and gentlemen. As the chairman said, that some of us being asked for the speaker replacement because of some speaker that could not come. Anyway, the show must go on. So this afternoon, I will deliver talk about addressing the unmet medical needs in unresectable HCC. So I just try to review the lenvatinib data. So as we know that there are so many selected drugs and molecular targets for HCC, and if we look from the previous presentation, that the common drugs that we use until now is sorafenib, and also maybe some countries also already starting using the regorafenib whenever the sorafenib is failed. However, looking the new data, that new development of drugs, lenvatinib has been considered is one promising drugs when compared to sorafenib, because as we can see here that lenvatinib works in so many target points when compared to sorafenib. And of course, this slide showing that the mechanism of action from lenvatinib, that it's not only it inhibit the angiogenesis, the tumor angiogenesis, but also that lenvatinib, based on the studies, also can control the tumor growth. Yeah. So it can work in the double receptor when compared to the sorafenib. So this slide just showing that how is lenvatinib's dual inhibition for the vascular endothelial growth factor and also the fibroblast growth factor pathways that is also considered as the two most important pathways in the development or the progression of the primary liver cancer. And we can see here that with the amount of the minimum concentration that lenvatinib have been able to inhibit the angiogenesis as well as the growth factor. So I don't know, maybe in many other Asian countries, that in Indonesia, lenvatinib has been approved in combination with everolimus for the treatment of patients with advanced renal cell carcinoma following one prior angiogenetic therapy, and also in combination with pembrolizumab for the treatment of patients with advanced endometrial carcinoma who have disease progression following the prior systemic therapy, and also when the people are not candidates for the curative surgery or radiation. And we know that based on the US FDA, that lenvatinib has been approved for the first-line treatment of patients with unresectable hepatocellular carcinoma. So this trial study about lenvatinib in HCC, you can see here that there have been the phase 1, phase 2 study about this drug. And lenvatinib 12 milligrams was the recommended phase 2 dose, and have been used for the Child-Pugh A as well as Child-Pugh B patient. And also the drug-related side effect, including the proteinuria, the disease-related, including the proteinuria, hepatic encephalopathy, and also the hyperbilirubinemia. And in the phase 2, this was a single-arm, open-label, multi-center study. Patients with advanced HCC who did not qualify for the surgical resection. And primary endpoint by the embraces criteria is about 7.4 months, and median overall survival is about 18.7 months. So pharmacokinetic and safety suggested that this should be the weight-based dosing for the phase 3 trial. It's 8 milligrams for patient weight, body weight less than 60 kilograms, and 12 milligrams for patient at more than 60 kilograms. So you can see here that the median body weight was lower in patients who had an early dose withdrawal or reduction versus in those who did not. And this is the recommended dose of the lenvatinib use. For the low body weight is less than 60 kilograms, can be used for 8 milligrams daily, and with a higher body weight is more than 60 kilograms, can be used for the 12 milligrams daily. So I think there was a very good non-inferiority study from Professor Masatoshi Kudo and his colleague. He's from Japan, just published in Lancet in 2018 about the phase 3 trial to compare the efficacy and safety of lenvatinib versus sorafenib in the first-line treatment of patients with unresectable HCC. And based on this study, is a global randomized open-label phase 3 non-inferiority study. And there is a lenvatinib versus sorafenib in the first line. As we can see here, that the patient with unresectable HCC, the amount of patient, almost 1,000 patients, where the patient has no prior systemic therapy for the unresectable HCC, and also has more than one measurable target lesion per embraces, BCLC B or C, Child-Pugh A, ECOG score is less than 1. The patient also has the adequate organ function, and patient with more than 50% liver occupation, clear bile duct invasion, or portal vein invasion in the main portal vein were excluded. So they tried to stratification whether this patient included the Asia-Pacific region or either in the Western region. And of course, they also divided based on the body weight. So this has two arms. So there were 478 patients in the lenvatinib group, and also the 476 patients in the sorafenib group. And this study tried to look the primary endpoint for the overall survival, as well as the secondary endpoint for the progression-free survival and time to progression. And also, this study also tried to see the quality of life of the patient. And then the tumor assessment were performed according to the MRSIS by the investigator. So if we look at the results, that this study showing that lenvatinib is non-inferior when compared to the sorafenib. You can see here it's not working. Okay, and yeah, and based on this study also, it been shown that with other combining drug, let's say like erlotinib and sorafenib and others. So it's the first line, considered the first line treatment, yeah, that has non-inferiority when compared to the sorafenib. Yeah. This slide showing the patient characteristic. So they try to divide between the Western group and the Asia-Pacific group, and also the Child-Pugh A class. So there were no so much different between the patient in the lenvatinib group and the sorafenib group. Also, they try to see the BCLC class B and C. And also the main etiology is between the chronic hepatitis B infection and the chronic hepatitis C infection. And of course, there's some small number of patients with the other etiology of chronic liver disease. And last one is they try to divide also by the base or the baseline, the AFP level. So if we look at the primary endpoint by the Kaplan-Meier analysis to estimate the overall survival between lenvatinib and the sorafenib, so we can see here that in fact there's no significant, yeah, even though that we significant, statistically significant, even though that we look here that in the lenvatinib group there's longer months in the overall survival when compared to the sorafenib. However, if we look in this the subgroup analysis, interestingly that the patient in the Asia-Pacific region, yeah, I think it's more favors for the lenvatinib when compared to the Western group. Yeah. And the etiology, you can see here also that hepatitis B virus infection more favors to use with the lenvatinib when compared to the sorafenib. However, that the mechanism or the basic mechanism about this virus comparing hepatitis B and hepatitis C is still unclear. Yeah. But based on the clinical data that is more preferred and maybe will be more suitable in the most Asian region, as the hepatitis B virus infection is still the major etiology of the chronic liver disease in most Asian countries. Yeah, and then if we look for the subgroup analysis, we look based on the AFP level. You can see here that even the AFP level is more than 200 nanograms per milliliter. So in the lenvatinib group, still showing higher results when compared to the sorafenib. And also the overall survival, we can see here that AFP level less than 200 is longer than the AFP level that more than 200. So we look the secondary endpoint, the Kaplan-Meier analysis estimate for the progression-free survival by the Embraces criteria. You can see here that there's a high statistically significant in the lenvatinib group when compared to the sorafenib. Means that in the lenvatinib group is higher for the progression-free survival when compared to the sorafenib group. And back again that for explore of the progression-free survival in subgroup analysis, that the more patients who have hepatitis B viral infection is more favors of the lenvatinib when compared to the sorafenib. If we look for the time to progression, and we look see here that there is a statistically significant when we compare between the lenvatinib group and the sorafenib group. And also the maximum change in the tumor size by the Embraces evaluated by the imaging evaluation. And you can see here that there's also the statistically significant reduction of the tumor size in the lenvatinib group when compared to the sorafenib group. And also that if we look further for the analysis in this study, the overall survival between the responders group versus the non-responder group, there's a statistically significant that a higher overall survival in the response group when compared to the non-response group when using the lenvatinib treatment. And also this only to show that about the possible adverse event of the lenvatinib and might be need the dose reduction. Yeah, these are the most frequent adverse events when using lenvatinib, such as the hypertension, decreased appetite, decreased weight, and also the proteinuria. So it has been recommended, for the first time for the dose adjustment. If let's say there's adverse event in the REFLECT trial, that management for nausea, vomiting, or diarrhea, of course, was initiated prior to the interruption or dose reduction. And also no dose adjustment was required for the first occurrence for hematologic toxicity or proteinuria. And if you can see here that based on the actual weight of the patient, of course, we can do the reduction if, let's say, that there's an adverse effect. So this is just want to show you that's the questionnaire we use to analyze the quality of life of the patient because the HCC patient mostly do have related symptoms, yeah, to concomitant underlying liver disease. And this questionnaire has been developed using the standard guideline to see the quality of life. And then if we can see here that if we look to compare between the patient treated with sorafenib, patient treated with lenvatinib observe delay in the dysfunction and pain, also diarrhea and other possible quality life effect. So I think my talk, ladies and gentlemen, Mr. Chairman, so lenvatinib has demonstrated non-inferiority versus sorafenib in overall survival in patients with unresectable HCC, and lenvatinib has achieved statistically significant and clinically meaningful improvement in progression-free survival, time to progression, versus sorafenib in this population. The safety profile of lenvatinib and sorafenib in the study appear consistent with those previously reported in patients with HCC. And then based on this result, that lenvatinib may be a potential treatment option, maybe not only in patients with advanced HCC, but of course, maybe in the future, we're not sure yet whether this drug also can be considered to be used in the early stage or maybe intermediate stage of HCC. With that, I thank you very much.
Thank you, Dr. Rinaldi. The next speaker, Professor Rino Agani. I think no need to introduce Professor Rino. He is the president of APASL right now. And Prof. Rino will talk about the role of lenvatinib for unresectable hepatocellular carcinoma case sharing. Please, Professor Rino.
Thank you, Mr. Chairman. Good afternoon, dear colleagues. My task today is to bring you the role. Actually, I want to emphasize in the case sharing of the use of lenvatinib that we can found in the literature. I thank the previous speakers because they already showed some data around the lenvatinib for the unresectable hepatocellular carcinoma. For refreshing that liver cancer, maybe you already know that for liver cancer, the 15% of the liver cancer is the cholangiocarcinoma, but most of the liver cancer is the hepatocellular carcinoma. In Asia Pacific region, liver cancer is considered high incidence. Indonesia is also the region where the liver cancer is high in incidence. And WHO estimated that more than 1 million patients will die from liver cancer in 2030. So it's more than coronavirus can kill. For epidemiology of liver cancer, you can see that in our region in Southeastern Asia is the second most prevalence of liver cancer after Mongolia. The highest rates are observed mainly in male patients. In Indonesia, we are maybe not the most prevalence in Asia compared to China, Japan, Korea, but this is also maybe because of the lack of good registry of liver cancer. As you can see, however, the Indonesia still quite high in the prevalence of liver cancer. In our institution, every year the incidence of liver cancer, the prevalence of liver cancer increase. As you can see here, the prevalence increased to 155 cases, new cases per year. Previous speaker already mentioned about the BCLC stages, and we can see that the HCC, BCLC C and D stage is a very poor survival rate compared to other BCLC stage. Really difficult to use this pointer. As you can see here, that BCLC is stage C and D. It's not really significant in the survival rate compared to BCLC A and B, and it's very poor compared to the other stage of BCLC stage. This one is the BCLC stage. The previous speaker already mentioned about it. And in our institution, the most prevalent BCLC stage is BCLC B and C. So our patients, it's not really not really fortunate, because the curative stage in these patients cannot be accomplished. So we will have to rely on palliative strategy and also with the systemic therapy. As you can see, that every year the prevalence is the same. BCLC stage B and C is the more prevalent compared to the other BCLC that can be curative. For treatment option for hepatocellular carcinoma, we can use invasive strategy with liver resection or liver transplantations. But most of the patients can have local regional treatment with RFA or microablations, or with transarterial chemoembolizations. And in the setting of the systemic therapy, this patient can have sorafenib or regorafenib as the first-line therapy these days. For treatment of our HCC in BCLC stage A, which not really prevalence in our patients, we cannot give ablations or liver transplantations. So we may rely on this treatment with chemoembolizations or with systemic therapy with sorafenib. And now we have drugs for first-line therapy other than sorafenib, which is the lenvatinib. This is the development of systemic therapy in liver cancer treatment. Sorafenib is the first drugs approved by FDA maybe some more than 10 years ago in December 2007, and still used until now. And we can see that not many development in the treatment of the liver cancer after that for the first-line therapy. And but fortunately, in 2018, lenvatinib is approved by FDA for treatment of newly diagnosed unresectable HCC. This is the molecule of lenvatinib, and mechanism of actions of lenvatinib is considered the same with sorafenib, but more multi-targeted tyrosine kinase compared to sorafenib. Previous speakers already mentioned the how the lenvatinib can suppress the liver cancer. So the tyrosine kinase receptor suppress the proliferative ability of the liver cancer, and also the angiogenic or tumor angiogenesis. Phase 2 of lenvatinib already mentioned by the previous speakers, and it showed that these drugs have a good efficacy for suppress the progression to time to progressions, and also the survival of the patients. This also already mentioned about the median overall survival of the patients with lenvatinib with the good results, 18.7 months. And for patients with body weight may influence the efficacy of lenvatinib, and this is also already mentioned by the other speakers. The reflex study, the last speakers already mentioned also this, and it showed that the patients with body weight more than 860 kilograms should have lenvatinib 12 milligrams per day, and patients with less than 60 kilograms should have 8 milligrams per day. And this is the phase 3 non-inferiority trial, compare lenvatinib to sorafenib, and it in overall the data showed that lenvatinib showed non-inferiority in overall survival duration compared to sorafenib. The overall survival of sorafenib of lenvatinib in favor of lenvatinib, as you can see here, for every items of the measurement, it's show the favors of lenvatinib. And the median progression-free survival of lenvatinib is better compared to sorafenib group. Compared to other TKA, the tyrosine kinase inhibitor, like brifanib or sorafenib and sunitinib, the lenvatinib showed treatment better compared to sorafenib. This already mentioned by the other speakers, that there is a strong evidence for sorafenib and lenvatinib to be used as a first-line therapy for liver cancer. For the the last guideline from EASL showed that the lymphatinib have been shown non-inferior to compared to sorafenib for the treatment of liver cancer with Child-Pugh A class, good performance, and in patients with BCLC C without main portal vein invasion. This also in favor for lenvatinib, as we can see that for items in the measurement of comparing lenvatinib and sorafenibs. For the safety, the lenvatinib compared to sorafenib quite comparable, and the most common treatment-emergent adverse event from patients with lenvatinib is hypertension, diarrhea, decreased appetite, and also decreased weight. This is the case sharing. A woman, 60 years old with hepatitis C virus. The first tumor was in 5 years ago, detected by the ultrasonography and CT scan. And then she received the radiofrequency ablation. And 3 years ago, the second tumor appeared, and also with multinodular intrahepatic recurrences with the portal vein invasion. She already also received the transarterial chemoembolizations, but just months before, after that, the taste seems to be refractory. So she began the trial with the lenvatinib monotherapy. This is the baseline physical laboratory examination. The vital sign normal, height is good, and the ECOG performance score 0. The Child-Pugh score was A, grade A. And the target lesion is in the segment 8. Yeah. It's considered typical of HCC with enhancement of arterial phase. And she began with lenvatinib 12 milligrams given once daily. And you can see at the beginning the enhancement in the segment 8, and after the treatment of lenvatinib, the enhancements reduce in arterial phase. But following 8 weeks after the treatment, the vascularity of the HCC seems to be decreased. The treatment was interrupted because of the grade 2 proteinuria, and then the enhancement of the tumor appeared again because of the treatment was stopped. CT scan after the initiation of the lenvatinib, after that, showed the decrease of the vascularity after the beginning of the treatment. 1 year later, because of the acute cholecystitis, the treatment stopped, and the CT scan again showed the increase of enhancement, which is increase of the vascularity. And after the initiation of the treatment, in this slide, the vascularity of the tumor decreased, and because of the, again, proteinuria revealed, the patients have to stop the treatment. Again, the enhancement of the tumor reappeared. But after the initiations of the treatment, the vascularity of the tumor again decreased. And the overall survival in these patients was good for 71 months. So levantinib monotherapy showed a long-term anti-tumor effect, and during the clinical course of these patients with unresectable advanced HCC. So ladies and gentlemen, dear colleagues, as a conclusion, lenvatinib monotherapy showed a long-term anti-tumor activity in patients with unresectable advanced HCC, and lenvatinib showed non-inferiority in terms of overall survival, as well as statistically and clinically meaningful improvement, also in progression-free survival and time to progression and objective response rate. No new safety problem until now were identified for lenvatinib. Thank you for your attention.
Thank you, Prof. Rino, for the clear presentation. Now we proceed to the discussion. I invite Dr. Aldi and Prof. Rino to come to the stage. Any question? Yeah, the first and the second, Dr. Mong from Myanmar. Yeah, please.
Thank you. Thank you for all the wonderful lectures. I have two questions. First, regarding the use of lenvatinib. So, as we know that large HCC tends to have a higher recurrence after liver resection. So, any potential benefit of using lenvatinib compared to maybe sorafenib, and when should we start? And the second one, regarding the unresectable HCC, sometimes the problem is pain. Any recommendation on how we can control the pain, including the use of paracetamol? Thank you.
The question for Dr. Lianda or all of the speakers?
Yeah, thank you for the question. I think it's a very good question. Yeah. Yes, the only problem is the data until now. I don't think there's still already data showing that the use of lenvatinib after the liver resection. But of course, if we talk about possibility of using the lenvatinib after liver resection, in fact, I fully agree with you, because I know that if we look at most of the data, that lenvatinib showing a very good response by blocking the two important receptor. So I think in terms of after resection, then to prevent the recurrence of the HCC, because we know that the HCC recurrence is still very high, even though the patient already underwent liver resection. So, in my opinion, I agree that to start to use the lenvatinib maybe after the liver resection. But of course, because This multikinase inhibitor also has anti-angiogenesis. So usually, maybe it's better to wait within a month after the liver resection, then maybe we can use. But however, in fact, there's still no data yet, about this. But maybe in the future, and I think we can use this drug even after the liver resection.
Dr. Lianda?
Yeah. Our data looked at we have transplantation, after transplantation for prevention of growth of the XCC. I think it is controversial because there is no data up now, until now, that for the transplantation. It is, the data is very, no much. So I think it is much controversial. It is giving or not sorafenib. I know that. But I think it is no data because new drug for it. I think it is my suggestion.
From my side, I cannot answer the question because we don't have data. I think evidence-based data to use the lenvatinib for maybe for the preventions of relapse in patients after liver resections. No, we don't have data on that. Maybe later, if we evidence will be a good one, maybe we can say something about it.
The second question may be about using paracetamol for the patient for the treatment pain.
Yeah, we know that treatment for pain in the cancer, I think it is same like other cancers. Initially, we give, it depends on the severity of pains. Initially, we have like not so high, like tramadol, and if there is failed to treat it, maybe we can choose morphine derived.
Okay, the next question from Professor Kim Mong Win from Myanmar. Please, Prof. Win.
Well, in this meeting, there are about 50 participants from Myanmar doctors. We don't care about the coronavirus. We fully support our Indonesian meeting.
Thank you so much.
Thank you very much.
Thank you.
It's not a really question. I comment upon my experience. We want to share the Myanmar experience about the sorafenib. We have participated, Singapore government funded 2 multi-center trials, sorafenib plus TARE. Sorafenib head-to-head with the TARE. I used about 350 patients. We used Bayer original sorafenib. And very disappointing, more than nearly 70% of the patients, we cannot complete the course. We have to stop because of the worst hand-foot syndrome. It's the worst in Myanmar population. So we have abandoned using sorafenib for the last 3-4 years. Then this lenvatinib came. Lenvatinib, except about 30% of the cases of hypertension, up to now, we don't see any serious side effects. And lenvatinib has been approved by the Myanmar FDA for the use in ACC, and we have used now for nearly 2 years without any serious side effects, and efficacy is very high. That's I would like to share our experience. Thank you very much.
Thank you, Prof. Win. So, based on Professor Win's experience, lenvatinib could give better response and better adverse event than sorafenib. Any comment, Dr. Rinaldi, your experience with lenvatinib?
Yeah, thank you, Professor Win, for your great comment. In fact, see, I fully agree with you, even though that maybe your experience is larger than us. But even in my experience also that very small side effect, I mean, for patients who use the lenvatinib when compared to the sorafenib. Maybe if we look based on the data review that I present today, that with only that minimum concentration that lenvatinib has already shown the good response when compared to sorafenib for the drug concentration in the blood. So maybe that's one of the reason why lenvatinib showing that less side effect when compared with the use of the sorafenib. That's my opinion. Thank you, Professor Win.
More question? Dr. Arras, please.
I want to ask to Dr. Lianda, in patient unresectable XCC or BCLCC, you treat with targeting therapy, and until not improvement, you change to immuno and targeting therapy, and or directly to treat immuno and targeting therapy. What do you opinion?
Yeah, thank you, Dr. Aras. It is not my opinion, but it is from, when I know it is from the, if you have treated patient with sorafenib, and for 4 weeks it is, the tumor is progressions, so you will change it to regorafenib. It is the study of sorafenib to the second line, it is regorafenib. Or maybe you have giving he or she with unpitinib and the tumor is progression, so we can choose for the second line, it is targeting treatment or immunotherapy. When you look in my slide, it is, there are 4 drugs can be used in the second line of treatment. Ravizurumab, cabozantinib, regorafenib, and the 4 it is immunotherapy, nivolumab and pembrolizumab. But in other study that pembrolizumab is failure to be treated with in the first line versus to sorafenib, and the second line, you know that immunotherapy only 50 until 20% can be used to tumor progression after the first line failure treatment. So there are no tumor marker for it. So I think it is very, very doubtful, and we don't know what the patient can be identified to give immunotherapy. We only give him or her blinded. So I think there are many studies, we have studied that combination with targeting with immunotherapy, but we saw that before it is failed to treat like second line treatment. So I think it is personally treatment. But we have some cases abroad that patient with XCC and then they are spreading to the pulmonary, and then from the pulmonary it is operated, and to identify genomic, proteomic, that it is identified to give some immunotherapy receptor, and the result is therapeutic treatment. So I think it is when we choose immunotherapy for the patient with XCC, mostly we have landscape of genomic before molecular basic before the treatment of the patient, because only 15 until 20% the good result. Thank you.
Thank you.
And if we can see the trial, the like immunotherapy like nivolumab or pembrolizumab, the setting of the trial is in patients with already refractory for sorafenib. So that's I think the main reason why we put immunotherapy as the second line, after the sorafenib. Only levantinib that have a trial that you can see the trial that this levantinib non-inferiority trial compare levantinib to sorafenib. So the result you already saw the data that so we can put levantinib and sorafenib now as a first line therapy for unresectable liver cancer. That's the thing in evidence. In evidence base that we have from the data. I think maybe some trial already with levantinib and pembrolizumab, and we are waiting for the result of this trial, maybe this year.
I have one question to Dr. Rinaldi. You mentioned that the time to progression and progression-free survival of lenvatinib was better than sorafenib, but the overall survival is similar. Can you explain why?
Yeah, thank you for your question, Larissa. Yeah, in fact, because if we look at data that, and we know that based on the mechanism of the lenvatinib, it can directly block the two most important receptors. I mean, the VEGF and also the FGF receptors directly. However, and the sorafenib is only blocked in one receptor, and it also needs the higher concentration when compared to lenvatinib. So maybe it shows that very good response when we use the lenvatinib when compared to sorafenib. But if we look at the drug classification, it's still in the same class, and showing that based on study for overall survival is only non-inferiority study drugs, when compared to sorafenib, because it's the same multi-kinase as an inhibitor. Until now, that's the only data that we have, but maybe even though that the overall survival is same, but seems that the response treatment is higher when compared to the sorafenib.
Thank you. I've been warned that the time is up, so we have to close this session. Thank you for all of the speakers, and thank you for all participants. Good afternoon, colleagues. Now we move to the state of the art lecture 1. The state of the art lecture 1 will be chaired by me, Irsan Hasan from Indonesia, and my co-chair, Colonel Dr. M. Julwan Pribadi, also from Indonesia. And we will have Dr. Towar J.M. Lalisang with the topics liver transplantation for small HCC. Where do we stand? Professor Towar Lalisang is a staff in Department of Surgery, Digestive Division, Cipto Mangunkusumo Hospital, University of Indonesia. Dr. Towar is also a former head of surgery installation of Cipto Mangunkusumo Hospital, University of Indonesia, and also the former head of Department of Surgery, University of Indonesia, Cipto Mangunkusumo Hospital. To Dr. Towar, the time is yours.
Good afternoon. Thank you, Chairman, for the nice introduction for me. And first of all, I'd like to thank the committee to give me the time to talk in this very high level and good meeting of an apostle in Bali. My topic is transplantation for small HCC. Where do we stand? No, sorry. Okay, it is my hospital. I think it's the same with our chairman today, Dr. Irsan Hasan. And it is also the nice slide when I start to talk about resection of the liver and liver transplant, because from this slide we can see the history of liver surgery when it started with the Prometheus and Eagle, where procedures, liver regeneration, segmentation of the liver, and HCC itself. We now have the procedure of to know the remnant of the liver, and also the regeneration of the liver. So it is confirmed after many years that the liver, after the resection, you can see here, the 6 months, the volume of the liver will come again. As we know that the HCC, I think everybody already know before that, it is the 6th most common neoplasma, primary liver cancer, causing of death, and the increasing frequent will be increasing right now. Already we know that the survival is very bad if poor survival if there's no operation, and we know the underlying disease as many of hepatitis B and C, especially in our country, this common of diseases. But what is the problem is that usually 80% of HCC is not resectable anymore. And as we know that resection itself is contraindicated if the liver condition is in child Puch B or C. And without treatment, usually after 6 or 9 months or 1 or 2 months, the patient will die. So the question is how we treat this kind of disease. Principle for the resection, I think, balance between the resection of the liver itself, the parenchymal disease, the diseased liver, and what is the remnant, so the patient still can survive with the remnant liver. And there are, in this slide, we can see that there are 3 factors that can improve or can influence the quality of the patient after operation. That means the
oncologic procedure must be done also if we are facing with HCC. The technical resectability, now we have many technique and good approach for the liver resection, and also the patient condition itself. As we know that 80% of the patients usually come non-operable anymore or non-resectable anymore due to the advance of the disease itself. But in the study of China in 2014, it is already declared that liver transplant in malignant prolonged survival and total free survival of the disease. Liver transplant is a part of a resection, but the problem is in the donor side. You can see also since ASD, SLD, they also introduced that liver transplant can make a good result for unresectable HCC and unoperable, I mean. You can see that the problem is how we choose the patient, the right criteria, so the patient survival will be good and there's very less of recurrence because usually HCC patient, if we resect, the recurrence rate will be the recurrence is very high in these cases, but with a liver transplant, we can prolong the free survival of disease. Here again, we see that when liver transplant is a part of the treatment of choice for HCC, because if there are some problem with vascular infiltration and very aggressive tumor, I think liver transplant is not anymore justified to make the resection because technically it is very difficult, and after the operation usually the recurrence will be very short, recurrence time. Again, it is already known, it is studied by University Medical Center in Brockville, that if you make a resection in the liver, that the survival will be going up or increasing, and recurrence-free will be going down. But the question is still, what kind of resection? That means that resection is the first choice if we are facing with HCC cases. So to make a good resection, if we like to choose the liver transplant is mean resection, not a partial, but will be total hepatectomy, and we need a donor. The criteria was very tight, so the recurrence and the quality of the patient, especially the donor, also will be still good. That's why now there are expansion of the criteria. Before, we only use the Milan criteria, where the criteria, one of the point is only the number of the tumor. So you can see that there are expansion and revolution of the criteria. Before, if there are already more than 3 nodules in the liver by HCC, it is not anymore be operate or to get a liver transplantation. And now we are talking about in worldwide, they use what they call the beyond the Milan criteria, because there are studies where the other criteria for HCC, if it is beyond the Milan criteria, the survival rate will be the same or more better than what Milan criteria mentioned and result. Because if we use only the Milan criteria, this means we have very limited of patients who can go, and many patients will drop out in the waiting list for liver transplant. Can see here that the expansion of the criteria, sorry that maybe you can see it is very small, but now in the criteria, what must be added? So we have also a good criteria for we can forecast when the recurrence will be very high in these cases. So now many surgeons or hepatologists may think about the behavior of the tumor. So one of the criteria, we put the marker of the tumor like IFP. It is put in the criteria. I think with that kind of criteria, what expanded criteria, the resection can be done and we can know what is the result for the patient. Here we can see that there are many criteria beyond the Milan criteria, like USFF, University of Tokyo, Asan Medical Center, or the very famous also criteria is the Hangzhou criteria. You can see here where they already put the behavior of the tumor, where IFP level is already included in the criteria to decide the liver transplant session. Here we can see the algorithm also for many centers that they also expand the criteria. Before, it is the liver transplant is very limited only in this criteria. Sorry. If we go to the NCCN criteria, the last version, we can see also that the liver transplant set is already expanded. It is not only very limited in the number of the tumor itself, but they are also added the behavior of the tumor, like to put the alpha-fetoprotein as the marker, and one also the differentiation of the ECC itself. It is also the version of ECC in 2017. I think it is the same also. But in our hospital, in Rumah Sakit Cipto Kamangkusumo, we can see that with this algorithm, we can also see that the criteria of, we not only use the number, but we use also the child-proof criteria, where transplant is still viable and can be done in our hospital if the child-proof is bad or poor, or more than B or more than A child-proof. So the resection cannot be done for a partial resection. And in our division itself, usually we use already the criteria if we would like to decide only to resect or partial resection or liver transplant. But the criteria, we already use the alpha-fetoprotein and imaging CT scan to know the number and the size of the tumor on liver, cirrhotic liver. We can see here that the point of section is in this area where if the liver function based on child-proof is A, then whatever the big of the tumor, we still can go for resection. But if even it is small and the liver function is child B or child C, so resection is not anymore the first choice for treatment this kind of tumor of ECC. Why ECC as indication for transplant? Because liver transplant, that means like it is written here that kill two birds with one stone. We can remove the tumor and by oncologic margin is free, and also the underlying disease if it is due to Hep B or C, or even due to the non-B, non-B, non-C. So whatever at the end of the now that many think that they are also mentioned that liver transplantation on HSC, it is a very good procedure from an oncologic point of view. So we can see the result if we make the LDLT, living donor liver. The problem is in the living donor liver transplantation, it is can also decrease, but in the part of area where there is no enough donor ready for liver transplantation, even it is a living donor, the dropout will be also increasing. The problem is still, it mentioned if we use a wrong criteria, the tumor recurrence following LT liver transplant is estimated to be approximately 7 until 20%. And that's why I think now the criteria of to make a liver transplant in a patient with ECC, we must use the criteria where there is not only the number of the tumor, the size, but the behavior of the tumor must be put inside, and we can calculate or decide when it can be compatible to go for liver transplant. If not, that means liver transplantation, it is not justified, even in we are using the cadaveric donor. From this slide, we can see that if we are facing with donor, the deceased donor, that means that living donor can the liver result for HCC resection is better than if using the deceased donor. It is only see on the in this also this slide that the survival is better if we use liver transplant versus the resection itself. I think it is also good. We can see the road. Now, in the hospitals itself, along about 10 years experience, we only make a liver transplant for HCC in 2 out of 3 adult living donor transplantation. Totally, we have already 7 living donor liver transplantation, but the others, due to HCC, only 3 patients. And all the underlying disease is due to hepatitis B and C. So, yeah, there are some theory that are what we call the salvage liver transplant, but I think it is, must be calculated very easily and very tight. So, in our hospital, if the the transplantation itself, it is just starting and come to a stabilized line. I think the salvage liver transplantation is still a question for what we can do in our hospital, or especially in Indonesia. It is the background, if later the best treatment for HCC influenced by the background of the liver cirrhosis, presence of portal hypertension, or also the underlying disease itself, as already mentioned before. And if we are facing with HCC, I think what we call now, how we treat before the condition of the patient or the cirrhotic state of the patient. If we can control the cirrhotic in the patient, the recipient side, I think the result will be better for liver donor living transplantation in this patient. So, in summary, liver transplantation in general, we know that it is already accepted worldwide that it is provide a good result, treatment of choice in most of HCC. Although this kind of procedures cannot be done routinely, because we must think about the tight criteria for that condition. And as talked before, that my question is, how about liver transplantation HCC? My answer is, according to the literature and the result of many publications, and also from the big center, that living donor transplantation, I think it is one of the choice of if we are facing with HCC in any child liver condition, and also in any condition of the patient itself. But the question is, for Indonesia, what is our opinion about that, according our experience and our cases in Indonesia? So to answer it, I think I like to make some conclusion that according our condition, surgery, whatever is this, resection partial or total hepatectomy, is the treatment of choice on resectable and operable HCC. I mean, the resectable can be seen by imaging, and not only because the size. Big size, it is not also a contraindication, as long the remnant liver is still enough for the patient. And operable, I mean, if the condition is in child PUC A. But if it is child PUC B or C, that means we must think about another treatment of choice, or we can approve the condition of B and C back to A. So in liver transplantation, in this, I think it is accepted in a patient with child B or child C criteria. Because liver transplantation give a better survival than resection in the later state. So my recommendation is to answer my question, how about Indonesia? Are we ready for donor liver transplantation? Even if it is ECC, I think we are ready. But if the patient have a child A, but a small tumor, I think we must choose resection first, anatomical resection for the patient. And we also must think right now, not only to expand the criteria, but I think we must make our Indonesian criteria by ourselves, because we are facing with ECC characteristics, special characteristics for Indonesia. So tumor biology also must be calculated based on our criteria. Okay, at the end, I'd like to invite all of you to come to our meeting also in Bali, 2021 in September, for the HPB-HPBA meeting. It is a meeting for a regional meeting from the hepatopancreatobiliary surgeons to talk about this kind of disease, also all of the problem of liver, pancreas, and biliary system. Thank you for your attention.
Thank you very much, Professor Tuan Lalisang. Since this is a state-of-the-art lecture, there will be no question and answer session. So please give a big round of applause once again to Professor Tuan Lalisang. And we close the session. Thank you very much.